So this is the second time that I am doing this because I didn't record the sound on the first time. So that's why there's writing all over the slides as I go through them. This is on antiviral agents. I'm going to talk about the specific viruses and those that respond to antiviral therapy. Remember, not all viruses do. If you just get a common cold, we just don't treat a common cold. And we obviously know about coronavirus. Now that's just one variant. There's a lot of different types of coronaviruses out there that are just like your run-of-the-mill common cold. So it's a little different. And obviously we don't have treatment for the COVID-19. So these are some of the things that we're going to talk about. We're not going to really focus on hepatitis B and C, although it's so nice because we have a cure now with medication for hepatitis C. Herpes viruses, we'll talk about the cytomegalovirus are treated the same, and then we'll focus on HIV and also about influenza A. What are some characteristics of viruses? I want you to understand that viruses are different than antibiotics, because antibiotics, viruses or bacteria does not need a host cell in order to synthesize and replicate. But viruses do. So they they go into our own cells and they replicate and then make more virus, and then they get spit out and then circulate around our entire system. They live inside our cells. And so any drug that kills a virus will also kill our cells. So that's why, it's a little bit harder to make antivirals. As you can see, there's the nucleus. The virus adheres to the cell surface here. There's pinocytosis, that term, remember, that it sucks it in. It sheds the viral coat. It replicates, synthesizes, and now look, there's new virus, and now it's being released. So the goal of treatment is to try to get the medication in as ASAP, as soon as possible, somewhere in here, before this happens. That is why with antiviral medications, if you've heard of when you test positive for influenza A or B, you want to make sure that you're capturing it within the next 48 to 72 hours. Because think about what happens as the virus keeps replicating. And once you're past that window, it's probably too late, and you're really going to only decrease your symptoms by a day or two. Antivirals in children obviously have not really been tested, although we can give, there is dosing for certain medications, like for influenza A, B, acyclovir also, if there's a herpes virus. And also just think with older patients, we always have to keep that in mind. With antivirals, we see a lot of liver toxicity, hepatic toxicity, so we want to make sure, remember, elderly with the aging process. Also, pregnant women should not be using them, other than the zidovudine is the one that can be taken in pregnancy, the only one that helps decrease maternal fetal transmission. All right, so now there's some common respiratory viruses. We'll talk about influenza A, ramatadine. It's the oldest drug for influenza A. I don't really prescribe it anymore now that Tamiflu is out, and there's other ones that are out now. But what it does, it prevents shedding of the viral protein coat. Because remember, we want to prevent more replication. So that's the goal. You want to start it within 48 to 72 hours. This one is notorious for causing dizziness, feeling off balance, and lightheaded. Here's some other medications which you don't need to know, but you probably are familiar with Tamiflu. But these are some other ones that are given for influenza A and B that are FDA approved. And the same thing, you want to capture and give it as much as possible. Now this question is saying you're caring for a patient that's been diagnosed with herpes simplex and are given a prescription. What should you teach this patient about their medicine? We took out when applying the drug topically, use absorbent pads. No, we don't want the drug to absorb into the pad, and we wouldn't be giving it topically if we want to decrease exposure to the drug. We just wouldn't be giving it then. Usually they will just get nausea, not really too much vomiting, and be sure to take most of the medication. I don't like that word most, so I'm taking that out. And so this, as we talked about viral replication, we want to take it as soon as possible, to improve the effectiveness of antiviral activity. So think antibiotics, you want to take the entire regimen, antivirals, and you can give antibiotics at any point in the infection. Obviously, earlier the better because we don't want the bacteria to get into the bloodstream, and then that's sepsis. Antivirals, we want to try to give it as soon as possible, early on, to avoid that replication. And yes, they should finish it in the time allotted. Okay, and that's the answer. All right, so herpes, cytomegalovirus, acyclovir. It's also given for shingles, which is basically the herpes virus. So we have genital herpes. So we have herpes simplex 1 and 2, genital and oral, although we see both in both places. Shingles, which if you have chicken pox, you have a lifetime supply of the chickenpox virus or the herpes virus laying dormant in your central nervous system or spinal column. If your immune system goes down due to stress, cancer, anything, you can have an outbreak and it comes out that nerve pathway. Once you see shingles once in real life, then you will know what shingles are again. A lot of people, when you have an outbreak, we call it viruses a lot of times outbreaks. When we see like a rash outbreak, a shingles outbreak, it's blisters, clusters of blisters. Same with herpes. It's all part of that same virus. And a lot of times people have a precursor to it. Now, especially if you have genital herpes or oral sores on your lips, sometimes you'll feel a tingling prior to it breaking out. And you're like, gosh, I feel like I'm getting a cold sore that's coming on. That's your signal to get your medication started right away. Some people with genital herpes get frequent outbreaks and they have to take acyclovir on a daily basis. Valcyclovir is also another drug that's in that same thing. It's Valtrex is the brand name. Don't have to know that, but acyclovir is on your med list. It can be given IV, also can be given orally, and it also comes in creams. You want to wear gloves, not because it's like an anti-neoplastic agent, but you just want to make sure that you're not spreading it in other places and just put it where it's supposed to be. And you want to start the drug, as I said, ASAP. This can cause some renal dysfunction. I know many of them cause liver, hepatic dysfunction, but the acyclovir and Valtrex, we have to watch kidneys. So if they have any kidney issues already, you have to really monitor and determine if that's the drug that they really need to be on. But drinking water and making sure it's being flushed out of the kidney. This name Zovirax used to be the brand name of acyclovir, but now it's generic, so you're not really going to see Zovirax anymore because it's cheaper to get the generic at this point. All right, we're going to switch over to HIV and AIDS. There's more classes than this, but these are the most common classes. I put the drugs that's on your drug list that you have to know about here, and now we're just kind of going through each one. I'm going to stay very focused on the stuff that you should really know. Understand HIV treatment. I circled all of the different classes of HIV drugs. There's the virus, and you can see that it attacks the virus at various points. So that's why you need to be on a multi-drug regimen. You can't just be on one because it's not going to prevent the virus from replicating. And when we are monitoring this, we draw helper T cells. That's your viral load. We want your viral load to be undetectable. That's the goal. And now people are living with undetectable viral loads. It used to be a death sentence, and they would get AIDS and they would die. Now we don't really see AIDS anymore. We see HIV patients with an undetectable viral load, which is great because if you do, and if you have a partner, you can have unprotected sex without any risk of transferring because you don't have any virus in your system, thankfully to all of the great drugs that have been made through the years. I just wanted to, you don't have to memorize this or anything, but it'll help you understand that usually you start with 2 of the NRTIs and then you add a third one here, one of these other ones, and it will just depend on your conversation with your provider as what's best for you. It's going to depend on, how your kidneys and liver are functioning. What's your viral load? What is the frequency? What works best? The initial one you take with food, and there is a simplified one over time where you can take it once a day and you don't have to worry about taking it with food. The goal of this is to take it long term and not be non-compliant with it. And it also reduces the risk of treatment failure, and it improves your quality of life. Imagine taking one pill a day versus tons of pills all day. It just reminds you of the disease that you have. There's a lot of absorption issues too. A lot of these patients have GI issues, so they're on antacids, H2 blockers like Zantac or Pepcid, the proton pump inhibitors, Prilosec, and as you can see, this was just to show you an example. You don't have to memorize this, but an example of how these drugs have to be carefully taken correctly. And so antacids, H2 blockers, PPIs, with pretty much any medication should be taken separately, just because absorption then is going to be altered. If you alter absorption, it's going to alter metabolism or distribution, the metabolism, then excretion. It's a cascade. This nevaparine, it works, again, you don't have to really understand the action other than it works in an area in the virus to prevent further replication of the virus. This one can be given orally. It's usually given orally, and it's metabolized in the liver as usual. GI-related side effects, so those are normal side effects. Blurred vision, headaches, those are all things that you would tell the patient these are side effects. And if they come back and if it's disrupting their daily life, then you can talk about possibly switching. But usually the risks of stopping some of these drugs outweigh the benefits of taking them. You just have to deal with the side effects. These are not life-threatening side effects here. This one here is the only one that can be given to pregnant women. So if a pregnant woman comes in and has her initial labs and finds out she's HIV positive, or she knows she is, this is the drug that's given through the pregnancy to hopefully reduce the maternal to fetal transmission. It does come in a syrup and a pill form. That's all you really need to know about that one. This one here is notorious for causing issues with liver function. But I do want you to keep in mind that all of these drugs can alter liver function. So we want to monitor labs for all of these drugs. So I'm going to get an AST, an ALT, a bilirubin. And if I see triglyceride levels here too and cholesterol, I'm also going to get a lipid panel. I also highlighted Stevens-Johnson syndrome. This one is more likely to cause that. But with any of these drugs, if someone comes in with a full body rash, that's a red flag, and you want to notify the provider, or promptly, that would be something that would be a priority over maybe some other side effects. That's more of a more severe adverse reaction. This fusion inhibitor does come IV, and this specific one is notorious for causing dehydration because patients can get severe diarrhea. So you definitely want to watch electrolytes with this particular drug. Many times patients go on other drugs because of side effects of these drugs, such as peripheral neuropathy. They probably have to go on a gabapentin to help with the peripheral neuropathy, because if you live with that, it's a horrible pain, burning, tingling, numbness. It's not good. Or insomnia. Maybe they're taking sleep pills. They have to take a sleep pill, antidepressants. So all these drugs aren't benign, but unfortunately they have to take it to keep the viral load down. This medication here, we have to watch for rhabdomyolysis, also monitor liver enzymes. Rhabdomyolysis is a acute breakdown of the muscle. If you see myopathy, that's muscle pain. The symptom of rhabdomyolysis is severe muscle pain. Like if you get a really hard workout and can't walk for the next 3 days, I'm sure your CPK is a little bit elevated. That's a muscle enzyme. But if you have rhabdomyolysis, this is in the hundreds of thousands and it's life threatening. So, IV fluids, you need to get all that flushed out of your system, and that would be more life threatening. Again, this I'm not going to go into more detail, but this is the one that you give for maternal fetal transmission to help prevent that. There's some local antivirals also, which I talked about in the past slides, but you can do creams also of the acyclovir, valcyclovir. But there's a Brevov. You can get that by the chapstick, and that's basically for cold sores on the lips, which is the herpes virus. But just know acyclovir because that's the one that you only need to know what's on your drug list and your study guide. And I don't need to go on that. And actually, these are just duplicates, I believe. And yes, that's it. All right, we're done.